Good evening, everyone. Welcome to the Stellenbosch Business School COVID and Vaccine in the Workplace seminar that I will be leading this evening. But first, I would like Prof Mark Smith, Director of the Stellenbosch Business School, to say a word of welcome before I will take over and introduce our panel.
Welcome to Stellenbosch Business School. Welcome to one of our first events with our new identity, and we're very proud that it's for this really very important topic. When we think about the impact of COVID pandemic, it's changed a lot. It's changed a lot, but it's really accelerated a lot. It's accelerated things like for us in terms of the use of technology, our tendencies to work from home, to work at a distance, to collaborate. But also we can say perhaps it's accelerated some of the ethical challenges that we face as managers, as leaders, as health professionals, as members of society. And that's perhaps one of the areas where we'd like to say we can make a contribution thanks to our commitment to responsible leadership. Responsible leadership for us is something that permeates all of our courses, much of our research, and we think it's part of our role in society. Not just responsibility for caring for the environment, looking after trees and water and those types of things, but our responsibility to the stakeholders that we serve, stakeholders that work in our organizations or external to our organizations as clients or recipients of services. And I think the challenges of COVID vaccination and the challenges raised by the pandemic really illustrate how responsible leadership can perhaps help us, not necessarily provide easy answers, because for wicked and challenging problems there are no easy answers, but at least perhaps give us some of the tools to address those things. So I'm very proud that we're here today to talk about these vaccine mandates and the challenges that we face. Ties in with what we think we should do as a business school, also ties in with our close links with the health sector. I'm speaking to you from the Belleville campus in Cape Town, and just over the way in front of me is the Tygerberg campus, where it's also part of Stellenbosch University, where we have a huge new medical centre, partly sponsored by the World Health Organization, the centre where they sequenced the Omicron variant, and we're leading the way in doing research in COVID and many other areas. So I think that crossover of business, society and health is really particularly interesting for us. Something that permeates many of our activities. We have a specialist MBA in that space, and that gives me a nice link to my colleague Renata Schoeman, who leads that MBA, but is also our host for the evening. So I'm very pleased to welcome you. Welcome to the esteemed panel who are going to guide us through this topic. And I'm really looking forward to it. Thanks so much for joining us.
Thanks, Prof Mark. So I'm quite excited. As Prof Mark said, I'm leading the MBA in healthcare leadership, and we're really trying to build bridges in healthcare across private and public spaces in South Africa to provide leading healthcare in South Africa. So it's a privilege for me to introduce 4 big names in the country which would form our esteemed panel tonight. The first is Professor Shabir Mahdi. You might know him. He's the Dean of Faculty of Health Science and Professor of Vaccinology at the University of Wits in Joburg. He's co-founder and co-director of the African Leadership Initiative for Vaccinology Expertise, or called ALIVE. He currently serves as the chair of the National Advisory Group on Immunization in South Africa, and is a member of the WHO Strategic Advisory Group of Experts on Immunization, or so-called SAGE, since 2019. Our second speaker is Aadil Patel. He's the practice head and director from Cliffe Dekker. He's the head at Cliffe Dekker of employment law practice, and he's a thought leader in his field and recognized for his in-depth expertise in employment law. And he has acted extensively for various employers in both the public and the private sectors. He has worked across multiple jurisdictions in Africa and globally. Susan Hall is an expert on philosophy and bioethics from the Stellenbosch University, where she has joined the Stellenbosch University Philosophy Department in 2013. She completed a doctoral study in 2010 and a dissertation on harm and enhancement, philosophical and ethical perspectives. Her current research interests include bioethics and the ethics of technology. Finally, I would like to welcome Dr Ronald Whelan. He's Chief Commercial Officer at Discovery Health. He's a medical doctor by training and also holds an MBA. He was associate partner at McKinsey from 2006 to 2013, during which time he co-led McKinsey's healthcare practice across sub-Saharan Africa. Since then, he has been involved with Spinnaker Growth Partners, and he was also founder of Healthforce, a leading telemedicine player in South Africa. Dr. Whelan has extensive experience in clinical and corporate healthcare, spanning more than 20 years and 25 countries globally. I would like to start off tonight to maybe discuss a little bit of the medical imperative on a mandatory vaccine policy. Prof Mahdi, if I can start with you, if you want to come on screen. And given the recent events at this stage, we are post the fourth Omicron wave. Where do we stand in terms of the scientific evidence for the effectiveness of the current COVID vaccines?
So, good evening, and thank you for having me. So, when we talk about the effectiveness of vaccines, I think it's important that we distinguish with regard to what we're trying to protect against. So, vaccines work extremely well when it comes to protecting against severe disease and death. Even when you've got a variant such as Omicron, which is relatively antibody evasive, and which is able to cause large amount of breakthrough infections in individuals, vaccines still have high levels of protection against severe disease and death. When it comes to how vaccines work in protecting against infection, that unfortunately is much more tenuous. To a large extent, it depends on when people have completed their vaccination, because you have this waning of what we refer to as antibody, which seems to be a critical mediator of protecting against infection, in addition to which you have the evolution of the virus, which makes it relatively resistant to the antibody activity, such as Omicron, which is antibody evasive. So vaccines work very well in protecting against severe disease, even when there's mutations that we've observed up until now, but work less well when it comes to protecting against infection. And even if there weren't these mutations taking place, what we observed in the past is that just simply the waning of antibody brings about a reduction in the effectiveness of vaccines in protecting against infection and mild COVID. So we'll discuss mandatory vaccination, I guess, a bit later, but it obviously brings to the fore, when we talk of mandatory vaccination, what underpins that is whether or not vaccines will be able to limit the spread of the virus, even if someone is infected. And that is the golden question, because if vaccines aren't able to reduce the spread of the virus, even if there might be a breakthrough infection, the case for mandatory vaccination, at least in places where people are gathering, becomes much more difficult to justify. But there's another dimension to this, which is somewhat different in South Africa as an example compared to a place such as New Zealand. And what we've learned over the past few weeks is that the most robust type of immune response that you can actually induce in an individual is where people have developed immunity as a consequence of both being infected with the virus as well as being vaccinated. So what we refer to as hybrid immunity. And as it transpires, this hybrid immunity, in fact, can overcome the antibody evasiveness of even Omicron, in that this hybrid immunity will work much better in protecting against infection as well as mild COVID, compared to immunity that's only induced by vaccines or only induced by past infection. Now, the reason why that is important is that even before the onset of the Omicron wave in South Africa, what we showed in a population-based survey in Gauteng was that 70% of people had been infected with the virus at least once since the start of the pandemic. And after the Omicron wave, that now sits at about 80 to 85%, probably across the country. So vaccinating those individuals can take them to another level of protection against infection, and take them to another level in terms of even if they have a breakthrough infection, they wouldn't transmit the virus. So I don't think that despite the high level of protection that exists across the country now, despite the modest rollout of COVID-19 vaccines, largely driven by past infection, there's still opportunity of us being able to bring about an attenuation in the clinical course of future resurgences by virtue of having people vaccinated.
So what I hear is that what I see perhaps is a lot of COVID fatigue on different levels, emotional levels, practical levels, economical levels. But I also see a big portion of the population becoming quite blasé about it, not adhering to other measures, social distancing, wearing their mask, being a bit more social again in gatherings. And you've mentioned, and if I understand correctly, our herd immunity then sits at 85%, which was the first target, but then we say, no, it's not quite that. We still need to immunize or can you explain maybe the concept of herd immunity better for us?
So we know we're close to herd immunity. So herd immunity in the strictest sense of the use of that term refers to a scenario when the virus simply is unable to transmit between people because people got high levels of immunity which protects them against being infected with the virus. And if they're infected, they're not going to transmit the virus. And with the Omicron variant now, you probably, even if you vaccinate 100% of the population, you're probably not going to get to herd immunity. So herd immunity is a concept that we peddled at an early stage of the pandemic before the virus showed such propensity to be able to mutate and before it became so much more transmissible. So herd immunity as a concept, we pretty much should discard it. It's not going to transpire during the course of our lifetimes, and certainly not to the current generation of COVID-19 vaccines. But what you're referring to is extensive population immunity and particularly protection against severe disease. And for that, we're already north of 70%. More than 70% of the population have got reasonable protection against severe disease. But we can do better. We can do better if we get people vaccinated, and especially if the goal is primarily centered around trying to minimize the number of people that end up in hospital and that end up dying of COVID-19, rather than chasing after an aspirational goal of getting 70% of the population vaccinated, we can accomplish the same, if not more, if we simply get 90% of people above the age of 50 vaccinated, because they are the individuals that contribute to more than 80 to 85% of all of the hospitalization and death from COVID-19. So that would be a much more targeted approach. But it really depends what your goal of your vaccine program is. If the goal of the vaccine program is to prevent infections, that requires another strategy. If the goal of the vaccine program is primarily to prevent severe disease and death, that requires another strategy. And that strategy is about focusing and prioritizing people above the age of 50 as a proxy for those individuals that will most likely have underlying medical conditions that predispose them to severe disease.
Thank you. So obviously we want to prevent severe disease, but then following the strategy of let's aim for 90% of people above the age of 50 being vaccinated, I think there's maybe a different perspective that we could look at. What about the young people, because they're supposed to be economically active? And Dr. Whelan, that leads me into the next question in terms of the business imperative for a mandatory policy. It's more than just the medical imperative. Now, Discovery is one of the organizations in South Africa which has implemented mandatory vaccination policy. Why this decision?
Well, thanks, Renata, much appreciated. Thanks for hosting us today. Great to be with you and my esteemed panelists. I think throughout the COVID-19 pandemic, our strategy at Discovery has been a three-pronged strategy: protect our people, protect our clients, and support South Africa. And through the vaccination program, we've adopted exactly the same response. So on the first pillar, we've seen vaccination as being both safe and effective throughout the different variants, as we've seen those unfold over the course of the last year, 6 months or so. So we've seen it pass through the Delta variant, we've seen it pass through the Omicron variant, and we've got data from the Beta variant as well. So in the context of vaccines that are safe and effective, it's a very effective tool of protecting your staff, certainly against severe disease and death. And I think the data is conclusive around severe disease and death, as Prof Shabir Mahdi points out, but also in protecting against some of the infection risk. So we do see some level of protection against infection risk, more so in Delta and less so against Omicron, but certainly some protection against infection risk. So we saw this very early in the process and saying, this is an additional tool in amongst all of the other COVID measures that we've put in place during the course of COVID-19 to protect our staff. And when one considers the extensive measures that businesses have put in place, hand sanitization, social distancing, work from home, and so on and so forth, this is just that additional layer of protection. And the more people we could get vaccinated, the safer our workplace would become. I think there's also related to that a legal imperative in terms of the Occupational Health and Safety Act. So within the Occupational Health and Safety Act, it speaks about taking all appropriate measures to do everything possible to protect staff, including protection against hazardous biological agents, of which a highly transmissible virus is obviously one of those. So our first year pillar was around doing everything possible to protect our staff, a layered intervention that built on everything we've done to date. The second pillar was then doing everything possible to protect our clients. And you'll know that we have many brokers either working for Discovery or working independent of Discovery, and they come into contact with clients on a regular basis. And this was our efforts to protect our clients. We also have numerous clinical personnel conducting wellness assessments across the business, in conducting life insurance medicals, and we needed to make sure that we were doing everything possible to make sure that we were protecting our clients from any potential contact with COVID. And once again, a layered intervention that built on the interventions that we'd put in place previously. And then thirdly, and I think equally important to pillars 1 and 2, is setting a precedent and hopefully playing some leadership role and role modeling role in South Africa in supporting the government-led response around the vaccination program. We know that we've made significant progress in the vaccination program, over 30 million doses of vaccines delivered, but unfortunately, they still only have 32% of the population fully vaccinated. So we're quite a long way behind many other markets globally, and certainly many developed countries in terms of fully vaccinated rates. And we felt like we needed to stand up and do everything we could to increase the vaccination rates across South Africa more broadly.
As you were talking about protecting people, protecting clients, and supporting South Africa, I suppose supporting South Africa leads back to protecting also the economic health of people and also the economic health of the organization. The lockdown has brought so many potential for us in terms of flexible working conditions, working from home, but it's not always sustainable for organizations to continue with that, and people had to return to the workplace as well. What has been the reception to the policy among your staff, and how effective has this policy been in increasing the uptake of vaccination?
I mean, it's been interesting. Discovery's core purpose is around making people healthier and enhancing and protecting their lives. So this really cut to the core purpose of Discovery, and that really resonated with most of our staff across the business. So, what we found was that staff really rallied around the mandatory vaccination policy quite early on. When we launched the policy in September last year, we had 22% of our staff vaccinated. By December, we had 94% of our staff vaccinated. As of today, we're just short of 98% of our staff vaccinated. So we've got about 260 people out of our 11,000 strong workforce that are going through an objections process at the moment around our vaccination. So that uptake has just been incredible, and we are very proud of how our staff have responded to the mandatory vaccination program and have embraced us. I think in addition to that, what we found is our staff have taken leadership roles in their communities. So really spread the message around the importance of vaccination and the value of vaccination in their communities. So there's been this knock-on effect. And then I think the third interesting response maybe worth mentioning is when we launched the program, we had an outpouring of gratefulness around staff who were particularly anxious about contracting COVID, particularly across staff with chronic diseases, recognize the risk from contracting COVID when you've got a chronic disease, worried about coming back to the office if there was any potential risk of being infected with COVID. So that particular cluster was very, very appreciative. And then, of course, we must mention that across our base, there were people, and are some people who are resistant to vaccination for a variety of reasons. We've given them full channels around objecting to vaccination. We're going through a very thorough process in evaluating those objections. We're engaging staff on a number of different footings. I think Mark alluded to it early on, and we'd like to believe we've taken a responsible leadership and a thoughtful and measured approach to engaging staff who are reluctant to vaccinate.
I just want to invite attendees as well that you're welcome to use the chat function. If you have burning questions, I will keep an eye on it and also pose it to the speakers as we go along. Ronald, you mentioned now that there are some employees that's obviously resistant to the vaccination, whether it be medical concerns, bodily integrity concerns, religious concerns. But it brings us to a very important aspect, and I think we are now starting maybe to go into the more tricky aspect of a mandatory policy, and that is the ethical perspective. I can just immediately think about, autonomy versus justice as from my mind, like, is it fair that some people are vaccinated or not? What about my personal choice? And I think, Dr. Hall, you're in an ideal position maybe to tell us a little bit about what are the ethical principles that are relevant to this debate around mandatory vaccination in the workplace.
Thanks very much, and thanks for having me. So obviously the big conflict here in terms of a medical ethics perspective is a conflict between the principle of autonomy, that is the right to self-determination, to bodily integrity, to make choices about which medical interventions you accept, and the principles of beneficence and non-maleficence, which is promoting good, promoting well-being, and also preventing harm. And there are many different contexts in which those principles come into conflict. And over the last 40 or 50 years within healthcare, there's been an increased emphasis on autonomy, a move away from a more paternalistic style of medicine where the doctor knows best and you sort of accept the doctor's advice, to a notion that the individual patient has the right to decide. But that, of course, comes with costs when people refuse vaccination, for example. But typically, we do give people a great deal of leeway in choosing to refuse interventions or which interventions to accept, even when doing so we judge that it will be harmful for them. So if people are competent adults, we typically do allow people, based upon their religious convictions or any other beliefs, to refuse interventions which might be, or which we might think are of as good for them, and that refusal would be harmful. The difficulty, of course, comes in when we're not just talking about conflict between autonomy and non-maleficence within a particular person, but when we're talking about autonomy for a particular person and harm to the wider society. And that is really the conflict that is relevant here. The other principle which you've just mentioned, which I also think is relevant, is the principle of justice. So if we think about childhood vaccinations, for example, there we have achieved herd immunity. Herd immunity is a public good. And even as Professor Mahdi has emphasized, even if we don't achieve herd immunity with COVID, we are still achieving extensive protection by these means. And that is also a public good. Public good is a good which, if it exists, everyone benefits from it, those who are vaccinated and those who are not vaccinated. And that does raise an issue of justice, because it might seem that those who are vaccinated are contributing towards the benefit, and those who are unvaccinated are then free riding on the actions of those people who do choose vaccination. And therefore the principle of justice is certainly relevant here.
So I think you mentioned that, never mind the public good then, which for us is, you can understand that concept. I mean, if we have children and they're in school and, they all had their childhood immunizations. Now we're talking about school children, we're talking about adults, we're talking about people in the workplace, about elderly people. How, if they are healthier and not putting pressure on the system, obviously it's good for all. But what about if we move away from just the individual, the person? What about public health? I suppose is still part of that public good. But what about also maybe to the people that's being criticized often in this mandatory policies, the businesses? What about a mandatory policy if it becomes a governmental policy? Where does ethics leave us then?
So that's an interesting question. I mean, if the purpose of mandatory vaccination is to promote the public good and specifically public health, then I think you've got to ask them questions about whose responsibility it is to promote the public health. Is it businesses and institutions? Is that what they ought to be doing? Or is the state perhaps also abandoning its responsibility and allowing business to take over that role, where perhaps they are a bit concerned or a bit hesitant to make vaccinations mandatory in other contexts? And again, there you've got to ask a question which again touches on something that Prof Mahdi has spoken about. If the best way to achieve protection or to limit the severe disease and severe illness and death is to get 90% of people over 50 vaccinated, and I would guess particularly people over 60 vaccinated, then a mandatory vaccination policy in the workplace isn't necessarily going to get us there. It's targeting young working people. And of course, there are advantages to that as well. I mean, I think everyone has a personal ethical responsibility to get vaccinated. But whether a mandatory vaccination policy instituted by a workplace is going to get you to that goal, I think that is another question.
That indeed then becomes tricky to negotiate the waters. And then we can also understand why there is maybe pushback from individuals or even other organizations against this. Ms. Patel, the legal perspective, are there any legal principles that are relevant to this debate? And I think the legal and the ethical debate can link very closely. Dr. Hall mentioned also, isn't the state abandoning some of the responsibility where organizations now stepped up in terms of the mandatory vaccination policy? But what are the legal principles relevant to this debate from an employer perspective and maybe from an employee perspective?
Thank you, and thank you for inviting me to speak at this forum. The challenge most employers have, and something that you've identified, is that the responsibility to encourage, compel employers to be vaccinated rests with the employer. So there's a shift of focus from the state to the employer. From a legal perspective, it would have made it easier had the state indicated that employees or persons should be are compelled to be vaccinated. So if you want to go into any employer or any public sector facility, you need to upload your vaccination certificate. However, what we have is simply a framework, a set of directives issued pursuant to the Occupational Health and Safety Act, which simply states that employers may implement a mandatory vaccination subject to a host of requirements. And what you then have is employers then having to, one, consult and or negotiate with employees to implement such a policy under the pursuant to the directives, and saying that in order to maintain a reasonable, safe working environment, it's reasonably practicable to implement a mandatory vaccination policy. Our courts have indicated that such a policy, what is reasonably practicable, is subject to collective bargaining, is one of matter of mutual interest. So you could potentially have employees saying, "You changing my terms and conditions of employment, I want to embark on industrial action." So that's certainly an argument. What we have thus far is employers have implemented a mandatory vaccination policy under the rubric of the Occupational Health and Safety Act. And we have only two at this stage cases which emanate from the CCMA. Now, the CCMA does not establish a legal precedent, but it does give us some sort of guidance as to what the Commission for Conciliation, Mediation, and Arbitration is thinking. In the one, which is the first CCMA case, which is the Gold Rush decision, an employer, Gold Rush, which is a limited payout enterprise, implemented a mandatory vaccination policy, went through, the employee applied for an exemption pursuant to the directives. The employee was then, employment was terminated once the exemption was declined. The employee engage and interface with clients on a daily basis. The employee then took that matter to the CCMA, and the CCMA upheld her dismissal on the basis that she was permanently incapacitated. The employee has since taken that matter to the Labour Court on review, and that will be dealt with in the fullness of time. There have been a number of media reports where a number of other organizations have challenged the implementation of a mandatory vaccination policy. However, those cases have been unsuccessful on a technical legal basis, that the applications were simply not urgent. So what we don't have in South Africa is authoritative a legal report or a judgment that talks about whether mandatory vaccination is permissible within the workplace. Also, what the cases have not dealt with is, and I think this fits into what Professor Mahdi and Ms. Hall has stated, is that the efficacy of the vaccine within a workplace, what is your purpose, what are you trying to achieve, and whether implementing a mandatory vaccination in a particular workplace will achieve your objective, and whether there are not other measures in order to achieve the similar objective. And I'm talking independently of the exemption process. The exemption process only comes into being once you've implemented a mandatory vaccination policy. But before that, we can see that in courts and at the CCMA, there's going to be debate about whether you need a vaccination policy at all, whether scientifically it is justified. So we're going to have to see a host of medical evidence being led when there's a proper court pronouncement. Thank you.
This is complex because what I can hear from the panel, obviously from a medical perspective, it seems that it's quite a firm case to be made for we should vaccinate. Whether we have a firm case for it should be mandatory in the workplace starts to become a bit more tricky. And then also if we look at the current situation where we have started reaching better and better population, and I'm hesitant of calling it great population immunity. I don't want to say extensive population immunity as yet. Prof Mahdi is the expert there. I think as Dr. Hall has mentioned, are we targeting the right people? You know, are we targeting young people? Are we targeting old people? But young people also as parents, and the other way around. In the current case, listening to the medical evidence, listening to the practical results that we saw in discovery, as Dr. Whelan mentioned, where there's also the relief from the people that was fearful of COVID, or also those that might be employees, which is at risk, people with comorbidities, for example. The relief when there was a mandatory vaccine policy. My question maybe to the full panel, and that's what we can maybe go into a little bit of a debate, because I'm sure there's differences of opinion here, is in the context of the current environment, do we believe that mandatory vaccine policies, although it definitely would have been relevant September, October last year, is it still relevant in March 2022?
So Renata, perhaps I can start off. And I think what we need to appreciate is that the science has evolved. Now, one of the most striking features over the course of the past 2 weeks is some results that were published, which actually shows that inadvertently, the most robust type of protection you can have against infection, as well as mild COVID, and probably decrease your chances of spreading the virus if you do have a breakthrough infection, is what is referred to as hybrid immunity. This is immunity that results both from a combination of infection as well as vaccines. And this hybrid immunity is so potent that it's able to overcome the antibody evasiveness of even Omicron, compared with people that already have immunity that has arisen because of being vaccinated or from natural infection. So inadvertently, this is not by design, and it has come at a huge cost in South Africa with regard to loss of life. Close to 300,000 people have died in South Africa from COVID-19. But inadvertently, we've ended up in a situation where the majority of the population after Omicron, probably closer to 80 to 85%, of the population have actually been infected with the virus, and the vast majority of those that would be vaccinated would be people that were also infected with the virus at some stage since the start of the pandemic, and they would have this hybrid immunity. Now, why is that important in the context of the discussion on mandatory vaccination? When we're having people gathered in workspaces, they might be now protected against severe disease. But what we're wanting to minimize moving ahead, especially for the next 1 or 2 years, until we know in what direction this particular virus is going, is we're wanting to attenuate the magnitude of future resurgences. So we are going to experience future resurgences. There's going to be another variant, that's almost a given. But if we can get this high level of immunity through hybrid immunity inadvertently, it will assist us in terms of attenuating the magnitude of future resurgences. Now, the reason why that's important in a workspace is if you don't have this high level of protection against infection and mild COVID, what you're going to experience when there is a resurgence is large number of clusters of cases in the workspace, in institutions, which is going to result in disruption. It's going to result in disruptions in that workspace. It's going to result in disruptions to the economy. So even though those cases are unlikely to progress to severe disease, they're going to basically bring about disruptions when we experience another resurgence in another 2 to 3 months. So this is not by design, and no one could have predicted that this is what would have transpired, that hybrid immunity inadvertently confers the best type of immunity against infection, as well as against mild COVID, over and above protection against severe disease.
Prof Mahdi, people were talking at one stage about unvaccinated people being virus reservoirs and increasing the risk for mutations and therefore increasing the risk for future waves. Any comment on that?
Yeah, I think that has become less of an issue with the extensive amount of natural infection-induced immunity that has arisen. But there are immunocompromised individuals where neither vaccines or past infection will result in a good immune response that will protect them against reinfections and that won't allow for sort of prolonged shedding of the virus in those individuals. So immunocompromised individuals still remain with vaccines and with past infection. And this evolution of the virus seems to be a feature of where there's prolonged shedding of the virus in an individual that is immunocompromised. So the more virus that continues circulating, the greater the chance that these immunocompromised individuals, which might be a handful, would be infected with the virus will mutate in that individual and spill over into the population, which is probably what occurred with the current variants of concerns that have been circulating. So I don't think there's much we can do in the absence of being able to eliminate the virus, and we're not in a position to eliminate the virus. I don't think there's much we can do to avoid this sort of evolution of the virus, even if it's just a handful of people that still remain susceptible to this prolonged shedding, which allows the milieu for the mutations to occur.
So from a medical perspective, I venture to be so brave as to say you would be quite pro a mandatory vaccine policy to still be implemented and to actually be enforced in other organizations as well?
I think in any situation where there's going to be people gathering indoors in large numbers, I think there's a good case to be made for mandatory vaccination, even in the context of high underlying natural infection-induced immunity. Like I mentioned, inadvertently we've ended up in a situation where hybrid immunity is superior to either of those mechanisms of immunity and probably protects against infection and spread of the virus, even in relation to a variant such as Omicron.
Talking for myself, I recently had to travel for the first time again since lockdown, and I was anxious at the airport and in an airplane, because for me, that is people in constrained places. It's a large gathering of people coming from all kinds of places. So I would definitely feel comfortable if there's more strict controls there. Dr. Hall,
except that you've got better air circulation in an airplane than you've got in your lecture theatre.
Most likely. Dr. Hall?
Yeah, perhaps I can comment as someone who caught COVID in the lecture theatre. So talking about the changing landscape, I think it's also the different contexts might call for different policies as well. So within the ethics literature, there have been certain preconditions that have been mentioned or have been argued for in terms of when you would want to consider a mandatory vaccination policy. So that would be there's a grave threat to public health, which I think that condition is met, that the vaccine is safe and effective. Again, I think that condition is met, certainly effective against protecting from severe disease. Of course, the difficulty there is that precisely those who resist vaccination are also likely to be those who disagree that that condition is met, who do not believe the vaccine is safe or effective. But the other conditions would be that the risk-benefit analysis of adopting such a policy of mandatory vaccinations, would be clearly superior to other alternatives. So then the question would be, does a particular workplace environment or institutional environment require a mandatory vaccination policy, or are other options available? Has engagement been exhausted? Have you tried to engage with those who are vaccine resistant? Is it possible for people to work from home, or is it necessary for, as in our case, who work in an academic environment, to come into contact with students? So, for example, in the context of a hospital, for healthcare workers, there's clearly a very strong case to be made for a mandatory vaccination policy, or heading in that direction, because it's inevitable that you're coming into contact with patients. And then the question is, the fourth condition would be whether the level of coercion is appropriate or proportionate. And the question then is, proportionate to what? And it would be proportionate to the risk of not instituting the policy or the benefits of instituting the policy. And there, I think the changing landscape, the amount of protection we already have would be relevant. So it may be that a policy was clearly, or mandatory vaccination policy was clearly the correct thing to do, as you said, November, December last year. And that is not as clear, I would argue, right now in all contexts, which is not to say that a mandatory vaccination policy may certainly be appropriate in some contexts.
Would it be just to abandon a mandatory vaccine policy once it has been implemented?
That's a very interesting question, again, because then you get to the question of free riding. So if you look at the case of Discovery, where, say, I think you said 98, but let's say you've reached 95% of your employees are vaccinated, and you then make the judgment that now we've achieved sufficient protection, so we no longer need to institute a mandatory vaccination policy. But then again, the question of justice arises, because then that 5% are free riding on the actions of those employees who have had to become vaccinated, or who have taken on the very small risks of being vaccinated to contribute to that level of protection. So there are questions of justice there, which are not unique to vaccination. I mean, there are many public goods that we contribute to that not everyone can, or that we all benefit from, that not everyone contributes to. But yes, I do think there are questions of justice there. There, again, I would argue that there's certainly an individual moral responsibility to accept vaccination in that case. Whether that translates into we must uphold a mandatory vaccination policy in the interest of justice is a more contentious issue, I think. It's clear cut.
Dr. Whelan, I'm not sure if you want to venture in now. How do you feel about this? And I'm asking feeling from a psychiatric perspective, because I think rationally we can still make very strong cases. But where we're now in this era, as Dr. Hall just said, maybe if you had to make the decision now for Discovery.
Yeah, I think it's an interesting question to say, well, the environment has changed. We as business leaders need to manage towards the future. And you can't make your decisions just based on what's happening now. And we've learned that from COVID. And we've gone through these troughs before. And it's amazing how relaxed and blasé we come through the troughs, and then another wave hits, and then we're all hands on deck again. And I think from a Discovery perspective, we see massive uncertainty still towards the future, and massive risk towards the future. And when you're looking at a future that is riddled with a potential new variant that may or may not be more severe than the existing variant, our experience in risk management is that you've got to do everything possible to avoid that potential calamity. And in the context of COVID, it's a question of building the strongest possible immunity wall heading into the next wave. Now, if the next wave is not severe, there's no downside in having that immunity wall. And if the next wave is severe, then there's a massive upside in having that immunity wall. And in our view, the immunity wall is, as Prof Mahdi mentioned, the immunity wall is partly built by the high seroprevalence in South Africa, is partly built by the vaccines that are additive on top of that, you're adding in to that hybrid immunity, and partly built by the existing measures we have in place now, most notably, I think, mask wearing. That's probably the most effective non-pharmaceutical intervention. So, in the context of massive uncertainty, best to have a strong immunity wall in place. And I think I do want to highlight the point around hybrid immunity. There was an interesting study out of Israel 2 weeks ago, published in the New England Journal of Medicine, that has shown that people who are vaccinated on top of prior infection are 4 times less at risk of infection than people who have just had prior infection. So we do have some good data now on transmission risk out of this particular study out of Israel, just short of 150,000 people in that study. And I think that's actually quite a good opportunity for us in South Africa, as vaccination on top of prior infection almost makes you bulletproof, as Prof Mahdi pointed to.
I'm also thinking now from maybe more from a business perspective, and I would be interested to hear Prof Smith's view on this, since he's still here as well. I mean, Dr. Hall mentioned that you can justify it if you can show that there's no other practical possibilities. Now, people often use the argument, yes, but I can work from home. But I think, Dr. Whelan, also in Discovery's perspective, it's not always possible to keep your workforce indefinitely at home. That also leads to challenges. We can think about cultural challenges. We can talk about how we measure productivity. So something might be possible, but it might not always be beneficial for the business then again.
Yeah, absolutely. I mean, I think you mentioned a few of the challenges in the work from home environment. I think the other one worth mentioning is we're seeing massive mental health challenges. So people working from home feeling isolated, and we've seen that both across our employee base, but we've also seen it across the Discovery membership base. So seeing a massive spike in mental health challenges across the spectrum, and I think that is largely driven by isolation and to some degree some of the other extraneous factors around the economy. And then I think what we're also seeing is capability building drop-offs, particularly in institutions that rely on apprenticeship. So for instance, and you'd be interested to get your Aadil's view on this, law firms, as an example, rely on apprenticeship to build their young associates through the ranks. We at Discovery rely a lot on apprenticeship, and apprenticeship is much harder to do in a work from home and a remote working environment. So certainly there's some pretty big business challenges in enabling long-term work from home.
You touched on 2 things that's very important. The one for me as a psychiatrist is close to home in terms of the mental health issues that we've seen a rise in. And initially with the lockdown and when people started working from home, they all experienced an improvement in their work-life balance. What we see now is that one of my patients put it so nicely. He said, I'm so tired of my boss in my bedroom and my children in my boardroom. So although we had good boundaries initially, during the lockdown and working from home, that boundaries have dissolved, and there's just more people working extensive hours, and that we find that if they actually go back to work, they recuperate better, not only for the social support, but also there's a more clear-cut boundaries again in place. And it also have implications for people with long COVID or post-COVID syndrome, where they argue for working from home, but in effect, it might be argued that it's actually better for them to return to home, to return to the office for the boundaries and the social support that they can have. Mr. Patel, I think what Dr. Whelan also mentioned is the apprenticeship, which must be something that is very practical, a problem for you also in your work environment.
Thank you. I think that under the Occupational Health and Safety Act directives and the Code of Good Practice on Disability, which are incorporated into the directives, if somebody is exempt, you've implemented a mandatory vaccination policy, somebody is exempted, you need to then determine whether you are able to reasonably accommodate employees. But what employees, or what we fail to realize, is that reasonable accommodation doesn't simply mean I'm able to work from home. And Whelan and Dr. Hall have touched on it. It's this culture, this training, mentorship are all important concepts, because we're not running, we don't operate cyber businesses. Because if that was the case, we would have had everyone working from home. But we underestimate the impact of collegiality, of water cooler training and mentorship. And we find, especially from a law firm perspective, that it's imperative that our young candidate attorneys are engaged with senior people so that there's a transference of knowledge. So when we say reasonable accommodation, and this you're going to see is going to be unpacked in court cases, because employees are going to say, well, I was exempted on a medical ground or religious ground, and you could have reasonably accommodated me to work from home. And the argument's going to be, we don't run a cyber business. And because we don't run a cyber business, we can't reasonably accommodate you to permanently work from home in perpetuity. And as a result of that, we've terminated your employment based on permanent incapacity. So whereas you could have been exempted, because you can't physically come into the office, and because your non-attendance impacts on our culture, on your training, mentorship, we've terminated your employment. So it's never going to be a defense for any employee to say, I can work from home, because in the long term, to a mandatory vaccination. And I think that sort of argument needs to be dispelled within the South African workforce, because it's coming up too often. And when we say, shall we get rid of the mandatory vaccination policy? Professor Mahdi says, and I agree with him, that we can't. We have at least 2 to 3 years as a duty to protect and create a safe working environment. Because if we don't, we're going to see an increase in sick leave, in productivity, and the like. And whether South Africa has moved, my final point is whether South Africa has allowed workplaces to be hybrid. Hybrid doesn't mean permanently working from home. Hybrid means you come in, whether it's 1 day or 2 days a week, but you have to come into the office. And in order to come in, you must be vaccinated. Thank you.
You made a very compelling case there. Prof Mark Smith, this must link very closely to Stellenbosch Business School, maybe how we're operating in our student environment as well. We students were really online for the largest part of 2 years. Some students have been allowed back on campus more recently. What do you see as the biggest impact on our, let me put it in brackets, hybrid learning then? When we often use hybrid learning as meaning online learning and you can come into the office, where Mr. Patel now clearly states that hybrid learning means you should be in the office, you should be in class.
Yeah. I was nodding vigorously when Aadil Patel was talking just now, because I firmly agree. We're not a virtual society. We're not a virtual education institution. We're not. Most of us are not working in virtual organizations. We're human beings that interact with each other, and that's the richness of coming to school, coming to university, coming to the organization, whether it's for those informal moments around the water cooler, or it's those spontaneous moments in the corridor, or whether it's actually the creativity comes from being physically in the same space. So I would I think we can't really pull away from that, or very few of us can, unless we're in a very sort of small set of occupations, or if we choose to study completely online. But I would argue as somebody who works in the education sector, studying completely online is a very much a different experience to having those interactions with human interactions with our peers, with our teachers, with our fellow students. And if you choose to do that, then you're making a life choice that's somewhat more restrictive. And if you choose to do that as a professional, as a worker, then you're also equally choosing yourself to make a decision that's somewhat restrictive as well. When it comes to the application of mandates, we're in the university, in Stellenbosch University, where there's a consultation process going on, and so we're working with that and waiting for that to come about, so we can decide how to proceed. But we're slightly less agile than in the sense than the private sector organisations that we just discussed previously. Many of the same, all of the same risks and challenges remain, because we're dealing with colleagues, we're dealing with clients, we're dealing with service providers, we're dealing with external stakeholders that come on campus, and it's we have a responsibility to those very much to those stakeholders. The other thing I'd add, if you just go back to the point before, is it was Ronald mentioned about listening and consulting, and the importance of that in terms of dealing with vaccine hesitancy. And a lot of organizations have seen that the hesitancy is greatly reduced once you do listen to people and hear about their concerns. And the health profession has sometimes made some decisions in the past that have been impacted on certain groups, and there is that mistrust might result from that. And we see studies in Canada about that, and where the health profession is mistrusted by certain Indigenous groups, for example. But I think it's important to say that the vaccine hesitancy is higher among the people without studies in the United States shows higher with those without a high school education. And so if we isolate those people who because of vaccine hesitancy, and those people are further marginalized from society, and then the risks, not just the mental health risks that you yourself mentioned, Renata, they're also risks of inequality and progression in society and social mobility that fall most heavily on those with the least education. And then if we add vaccine hesitancy and the consequences of that on top, then it's really a big concern. So I think it's beholden on us to listen and to consult and to reduce those levels of vaccine hesitancy for multiple reasons, for both health and current health, risks of COVID, mental health, but also those the risks of social inequalities that are perhaps worse than all of those other things, because they last a lifetime, and they impact upon the children and the children's children, and et cetera, et cetera. Thanks.
Thank you, Prof. Mark. While you chatted, I saw in the comment you asked about the free riding concept, if that suggests that there any danger of vaccination, or what is the free rider concept? My understanding is more that the free rider is that we all work towards the common goal and you didn't pull your weight. It's not that there's really risk that you not feel someone is carrying a risk that other don't carry. Dr. Hall, maybe you want to clarify on I think you were the one that mentioned the free riding.
Yeah, so I didn't mean to suggest that there are significant dangers to vaccination, but there's no such thing as you know, a vaccination that is 100% risk-free. We always have a small amount of risk of someone having an adverse reaction. So I mean to suggest that those who are being vaccinated are taking that very small risk in the same way that if you vaccinate your child, you are taking on that very small risk. And it then becomes, perhaps works a little bit better for childhood immunizations, because if you have achieved herd immunity because 90% of people are getting their children vaccinated, then you are at less risk. And then it becomes perhaps even the rational thing to do to refuse immunization, because you're protected anyway, your child is protected anyway by the actions of others, and you then don't have to take on that very tiny risk. But then it's the question of free riding then arises. So certainly I certainly agree that vaccines are safe and effective, but that doesn't mean that there's absolutely zero risk attached to them, as there isn't for any other medical intervention. So that was what I was getting at there.
Just to say, a colleague or close colleague is a toxicologist, and she would say there's risks to everything in life, including drinking water. You can have too much of anything. So I think it's important to say I agree that there are risks of any activity in life.
There's a comment from Johannes Skater that say it would be great if at least one of us aren't 100% pro-vaccination to allow for a more healthy debate. I trust that all of us are informed and objective enough to give an objective opinion and represent the science accurately. I can say for myself, I am vaccinated, but my biggest reason for being vaccinated, because at the time that I was vaccinating, I had a small baby. And I felt as a mother, given the evidence, the best way I could protect my baby was to try to give him antibodies. So that was my informed decision, and I discarded my risk factors, which I have. I'm also a medical doctor, so I believe that was the right thing to do to help to protect the overload on the hospitals. But that is my personal stance. But I do trust that we also invited the people that is in the panel to be objective and informed by science. I'm not sure if there's any other opinion from the panel.
Yeah, I'm happy to venture there. It's not about being pro-vaccination or anti-vaccination. It's about following the science. And as an example, I certainly wouldn't be advocating for vaccination of children under the age of 5, because the science is quite clear that firstly, those children are at very low risk of developing severe disease. And in fact, vaccines don't work too well in that group of individuals in whom the primary goal is to protect against infection. Vaccines don't actually work at all. So I certainly wouldn't be advocating for vaccines in the less than 5-year age group. I would extend it even further. In the 12 to 18-year age group, the risk-benefit ratio of vaccines in that age group, especially the messenger RNA vaccines, you can question it. And especially in the context of South Africa, where a significant percentage of that age group also have already got immunity because of natural infection. When you look at the Pfizer vaccine, in particular in boys, the risk-benefit ratio is pretty much on the fence as to whether you should be using vaccine in that age group. So it's not about just being blindly pro-vaccination. It's about following the science. And the science is clear that at the end of the day, even in South Africa, during the course of the Omicron wave, 85% of people that ended up in our hospital with severe COVID in the Western Cape were unvaccinated. You can't dispute that. So we need to be clear about the narrative here. It's not about being pro-vaccination or anti-vaccination. It's about being informed by the science.
Yeah, I would support that view as well. I mean, I think from a discovery perspective, firstly, there is enormous research around, both internationally and in South Africa, and we've had the pleasure and the privilege of engaging Prof Mahdi at regular intervals, along with all of our other scientists, Prof Glenda Gray and Prof Salim Abdul Karim, and so on and so forth. What we've also done is we've done our own data analytics. So we've deployed our actuaries against analyzing the outcomes across our members, bearing in mind Discovery has 3.5 million members, and we've seen just short of 600,000 people infected with COVID across the Discovery membership base. We've seen over 70,000 hospital admissions as a result of COVID. So we've been analyzing the data all along, and we were able to compare members who are vaccinated versus members who are not vaccinated, and run those analytics together with our actuarial teams, vetted those outputs with the scientists. So it's very much a science and data-driven approach. This is not a feeling one way or the other. You've got to weigh up the different scientific evidence available. I think in addition to that, also important to point out that when we kicked off, we're contemplating the mandatory vaccination program, we got some really brilliant counsel from Justice Edwin Cameron, who spoke about his experience during the early days of the HIV program. And one of the pieces of advice he gave us is, he said, by all means, the law is there and the science is there, but engage in a mutually respectful manner with your employees around this. Listen hard for those concerns, take those concerns on board, really get into the shoes of the employee. So throughout our objections process, that's been our mantra, is mutual respect in engaging our employees on this. And we've learned a tremendous amount through that engagement. And in fact, a number of those objections we've deemed both reasonable and justifiable for a variety of reasons: belief reasons, cultural reasons, religious reasons that were not necessarily scientifically backed. So it's a question of finding this balance between following the science and then also making sure that you take all the other factors into consideration.
I would also like to add that the purpose of tonight was not to debate, to vaccinate or not to vaccinate, but to debate mandatory vaccines in the workplace. You know, what is the debate surrounding that? And Janine now made a very good comment also. There's a case for a clear public communications campaign, informing people regularly on the science, the data. And I think that's what I've been seeing through these years, and maybe what everyone has experienced in the past 2 years, is how divisive the debates can become on social media, instead of maybe highlighting what I think Dr. Hall did so clearly, to say that there are 4 preconditions and that we're actually all working towards greater public good here. And the 4 preconditions, if I can put a reminder, it was there's grave threat to public health, yes. It's safe and effective, yes. There's a risk-benefit analysis that is scientifically superior to alternatives, yes. But Dr. Hall mentioned that maybe the one thing we need to look at and consider is the level of coercion. Is it proportionate to the risk of not implementing a mandatory vaccine policy? So I think it's important to look at the focus of the debate and also the narrative that the media carries, and also what we as individuals take into the social media space and our own personal communications, and step away from the divisive narrative, but really to more coercion and how we can all work together instead of opposing each other in this debate. Any other questions from the attendees?
Yeah, then I think if I can just, there's a comment that was sort of posted by Johannes Ketter about the UK, where the majority of people that are hospitalized are vaccinated. That is true. That is known as Simpson's paradox, where when you got 90% of the adult population vaccinated, even a vaccine that's highly effective, the majority of the people that are going to be hospitalized with breakthrough infections are going to be vaccinated. So it's Simpson's paradox is a manner in which you interpret data. If you take the same UK data and now you interpret it in relation to the incidence of hospitalization between vaccinated and unvaccinated people, then you see a 90% difference in favor of vaccination, where they're less likely to be hospitalized. So this is an example of a superficial read of data, which leads to a very sort of different answer than what the reality is. And similarly, it goes to the issue of the FDA having released all of these Pfizer so-called adverse events, which everyone is becoming excited about, but without actually interpreting the data. And what the data eventually tells you, firstly, is not only vaccine-related side effects or adverse events that's been reported, is a whole collection of data that's been dumped into the public domain. And when you go down into it, the likelihood of dying, of having a fatal side effect of the Pfizer vaccine, it does exist in the region of 1 per million. The likelihood of dying of a lightning strike in South Africa is in the region of 4 per million. So when we look at data, we need to be careful how we interpret it. At a surface, taking typical things at a superficial value unfortunately lends itself to incorrect conclusions.
I think that links what you mentioned now about the UK data to a question from the audience that Dr. Whelan mentioned Israel. Why is that countries like Israel with the highest vaccination rates are also the highest infection rates?
Well, because vaccines don't work too well in protecting against infection to start with. And when you look at Israel, it is not the most highly vaccinated country. It's a myth we need to dispel. In fact, the high-risk groups in Israel have only got 75% vaccine coverage. And that's the reason when you got a highly transmissible variants such as Omicron, you get mopping up of infections of those people that are still susceptible, that are largely unvaccinated. And consequently, you get a surge of cases that transpired in Israel. And again, the Israel data itself shows 90% protection against severe disease due to Omicron in vaccinated people relative to unvaccinated people.
That's such an important point that, and this is a very common myth that Israel is the highest vaccinated population in the planet. They're not. It's about 67, 68% fully vaccinated in Israel. When you compare that to countries like Portugal and Spain, where you're approaching levels of 95 and 96% of the population fully vaccinated. And when one considers 66% of your population fully vaccinated, that means 1 out of every 3 people is not vaccinated, and that still poses a significant transmission risk across that population. We've seen an interesting pattern, by the way, across, and you've probably seen in the media recently, there's a big spike in Hong Kong now. So Hong Kong has seen the sort of exponential curve on infections and indeed deaths in Hong Kong, which is quite concerning, which was a strange phenomenon, because in other countries like New Zealand, you're seeing a spike in infections but low death rates. What's happened in Hong Kong is that two things. Firstly, the vaccination rates across the elderly populations are less than comparator populations, so they have lower vaccination rates across people over the age of 70. Secondly, their booster uptake in Hong Kong is lower than comparator populations. And thirdly, is a further factor at play in Hong Kong. About 50% of the population is vaccinated with CoronaVac and about 50% with Pfizer. And we know that the CoronaVac is less effective against your Omicron. So you got to really dig into the data when you're looking at some of these charts. And unfortunately, the media tends to create a frenzy around these exponential curves.
I always think the media is such a good ally for us in terms of information, but there's such a big onus on them as well to make sure that information is not reported sensational, which is the point sometimes, I suppose, but really to educate the population, especially in pandemics like now. So Janine asked, so how do we get the right data out in public? Perhaps that linked to what I said now, that responsible reporting, making sure you talk to the right people and have things maybe read by the people that you interview before it's being published. But yeah, Janine, I think we've touched on that. Should government not be taking a leading role? But that might be going back to one of the things that Prof Smith mentioned, that people might have lost their trust in the government, and we might see that they are feeding into maybe some of the divisive narratives as well.
Yeah, tricky terrain. I'd love to hear Shabir's points on this as well. As Prof Mahdi mentioned, following the science is a reliable way to start around this. I think the one thing that has come out of this pandemic, and I think we should be very proud as South Africans, is our scientists have really risen to the fore on both the treatment of COVID, the genetic sequencing of COVID, the vaccine development around COVID. I mean, I think we have demonstrated we've got a strong scientific base, and indeed globally, I think our science has come back to the fore. Government is an interesting one. I'll share with you an interesting anecdote. I mean, I think the National Department of Health and Government more broadly has really done a great job in terms of the COVID response as well as the vaccine program. But you've got to look at the numbers quite carefully as well. So, for instance, we have 92,000 reported deaths as a result of COVID in South Africa. But when you compare that to the excess deaths, so in other words, the deaths in addition to what we would have expected for the same period, we see 300,000 excess deaths in South Africa since May 2020. Compare that to the 92,000 that are reported. And that's not to say that the 92,000 reported is a wrong number. It's just that that's what you could see in the data, correctly reported by government, but the actual number is closer to 300. So there's a nuanced understanding around this data.
Yeah, Susan.
I just want to jump in and say it's not only distrust of the government that is an issue, but I think a worldwide phenomenon that isn't just relevant to COVID, but distrust of experts. I think there's increasing distrust of experts and more reliance on social media, very much driven by social media. And the other thing that I think we can note specifically with regard to vaccines is, in a way, they are victims of their own success. If you look at vaccine resistance, which predates COVID, resistance to childhood vaccines, for example. One of the issues there, perhaps, is that vaccines have been so successful that they have more or less eliminated diseases which would have been very prevalent and very obvious to people, and the effects of those. And when that happens, the risk of not becoming vaccinated or not getting vaccinated isn't as clear as it would have been in the past. So I think that's an important thing to note as well.
Yeah, but also perhaps, I mean, I would respectfully Dr. Ronald about how well government has dealt with the COVID pandemic. Had we dealt well with the COVID pandemic, we wouldn't have had 85% of the population infected with the virus. We need to be clear. We have a lot of regulations, restrictions, which didn't achieve much in terms of preventing infections. All that it did is that it grew out the infections over a bit of a longer period of time, which was important at one stage of the pandemic. When it comes to COVID-19 vaccines, it's been an absolute disaster. Let us not kid ourselves. When we had vaccines available in January of 2021, and we went against the World Health Organization recommendation for the use of these vaccines, even though beta variant was circulating, that came at a cost. It came at a cost of 50% of all of the COVID deaths that transpired in South Africa having occurred during the course of Delta variant wave, which was avoidable. Yet we used the vaccines that were available to us instead of trying to toss it off to other African countries. Each time, government has taken misstep after misstep when it comes to COVID-19 vaccines. When we advocated for a heterologous approach before the Omicron wave, and when we advocated for the booster doses of high-risk individuals before Omicron wave, government didn't do that either. They're doing it after the Omicron wave, which is pretty much futile. Right now, government is not clear in its mind in terms of what the goal of vaccination is. If it was, it wouldn't still continue chasing after an arbitrary target of 70% of the population needing to be vaccinated. We're beyond that. We're way beyond 70% of immunity against severe disease. If government were to focus and tell itself that the main focus and everything else aside is to get more than 90% of people above the age of 50 vaccinated in the next 2 to 3 months, we would be much better off than chasing an arbitrary target of 40 million people or 70% of the population, which is set a target for the end of 2021, and we won't reach the target even at the end of 2022. So I think we need to be stopping polite to government. It has failed. It has failed dismally when it comes to a strategy around COVID-19 vaccination.
Thank you. There's another question that South Africa has a very high SME environment, informal economy. What can be, I suppose, done to communicate to these groups on the importance of mandatory vaccines?
I mean, I think the first thing to say there is a number of SMEs have already implemented mandatory vaccination policies across their different businesses. And we see this on a day-to-day basis. Remember, we have a number of SME clients across our discovery base. I think also what's happened, and this is important if you're a corporate on the call, we've seen through the implementation of our mandatory vaccination program that a number of the SME suppliers into our base have had to conform to us. So you're not allowed in the discovery building as a supplier if you're not vaccinated. So it's had a ripple effect on the small and medium-sized enterprise environment. I think the informal economy is a challenging space, and I think we've seen this as part of the vaccination drive in South Africa as well. In that it is not easy to get vaccines out into the broader community. It's not easy to drive that uptake. People in the informal economy have other priorities that they're focusing on. Really, just trying to survive day to day. So this does tend to filter down the priority list. So I think the efforts around communication, the efforts around getting vaccines out into the peripheries, community mobilization efforts are critical, but it's challenging terrain, and I don't want to beat about the bush on that at all.
Any other questions from the audience? There's one coming in. Janine mentioned a recent media article referred to transport costs as one of the main reasons people have not been vaccinated. I think there's various things that adds up to, even from a practical environment, although vaccination is now available over the weekend as well, I think it's sometimes different if you do not have people, or perhaps people that's contract workers that's employed by someone on a day wage to give up your day wage to go and vaccinate. If your employer don't support the initiative, you should just get paid leave for the day. But people have different perspectives. So I think there's various reasons that we can look at, that practical reasons why people are not being vaccinated, but there's also now mobile vaccination places that go out into the community. And I think it has become much, much more accessible over the past couple of months. Ronald, you might be knowing more about the community initiative.
I mean, other than to say tons and tons of work being done on all of those initiatives, and extensive, I guess, public-private partnership. I mean, there was, to give you some example, there was an initiative that's still running to date around going out and vaccinating people in social grant queues, which I thought was very powerful, because that is one trip a month that you make to collect your social grant. You're able to get vaccinated at the same time. But there are thousands and thousands of social grant pay points available on a monthly basis. So there's massive logistics around these exercises. And I guess more broadly, there's over at the peak we had over 3,000 vaccination stations across South Africa. So certainly had a I would say reasonable access. But as we know with healthcare, 5 kilometers is a long way to travel for healthcare, and that's why most healthcare systems, and if you look at the stats here globally, healthcare systems typically aim for that 5 kilometer radius. But when it's taxi fares or you're walking that distance, these are even 5 kilometers is a challenging distance.
We still have a couple of minutes. Is there any other questions from the audience or any final comments from the speakers?
I mean, I think we need to appreciate is that we're in a very different phase of the pandemic right now. And for all intents and purposes, we are in a recovery phase and heading towards the pandemic pretty much ending and the virus becoming endemic. And in fact, just an analysis from the UK today indicates that moving forward, given the extensive amount of immunity that exists against COVID-19, that the number of people that will likely die of COVID-19 in 2022 will be less than the number of people that die of influenza. And we've made a similar sort of estimate for South Africa. But it doesn't mean that the virus has disappeared. The virus is still in our midst and will be in our midst for the rest of our lifetime. But it speaks to again, government and its inability to keep up with the science and inability to actually bring about rational decision-making. This morning's headlines in the Business Times, which suggest that government plans on maintaining the state of disaster. The only state of disaster that currently exists in South Africa's government itself and its inability to manage healthcare services, not COVID-19. So it's really, really unfortunate that we talk about what great scientists we've got in a country, which we do have, and government speaks about following the science when they pretty much seem to be oblivious to what science is actually telling us at this point in time.
So I'm jumping in. Just because I was very interested in that question about small, medium-sized, small and very small, medium-sized organisations, and that I think there's a number of characteristics of the South African economy that are different to other countries where there have been vaccine mandates and wide-scale rollouts of vaccines. And that does lead to particular challenges. And I think to follow on from what Prof Mahdi just said, is I think that's where the government should be stepping in, because that's dealing with the challenges of the informal economy, dealing with the challenges of the geographical dispersion of the population and access to healthcare. So you can sort of somehow rely and devolve the responsibility to the corporate sector for those people that work in that sector, but then for the going back to my point about inequalities, going for those people who don't work in the corporate sector and do work in the informal sector, then I think there's most definitely a role for the state to be bold and to show leadership in that space to provide access to health, access to vaccinations, and consult and communicate to fill that gap that's that would be filled by managers and consultations inside the organization, as was been going on in Discovery. And I'd just say for the location of small and medium-sized organizations, they do face additional challenges, but they face additional in terms of having the capacity to run those consultations and to listen to staff and to encourage vaccination. But equally, they face challenges when their staff disappear because they're sick, or when everybody's a contact case, or a large number of people are a contact case because of that. So I think it's those challenges are very real for the small business sector, but they also the risks of spreading COVID, of having employees that are impacted by COVID, or the risks of the clients that they serve as providers is very real as well. So thanks very much.
I think we come to the end of the evening, but just an interesting thought and maybe a a potential future webinar. There was a question: compiling a vaccine policy for a workplace can be quite a daunting task. I would say quite as a euphemism, but quite a daunting task for businesses. Would corporates such as Discovery be willing to do a learning guide to share their lessons, challenges, tips, etc.? Ronald and Aadil, I think there is maybe an opportunity for you that we can maybe consider something, but I will leave it to, I don't think we need to answer this, but that is something maybe to think about. It brings me to the end of the evening. I would like to speak, to thank firstly, before I thank the speakers, Stellenbosch Business School, the Department of Marketing, Bendu and Janine Nell specifically, and Paula that's assisting tonight in the background, and the other people from IT for putting together the webinar and all the logistical arrangements. Thank you very much. I think it's very informative and a very important topic that we should have to debate. And then also a great thank you to our speakers, Prof Mahdi, Mr. Patel, Dr. Hall, Dr. Whelan, for making time in your diaries, despite all the other important work that you're doing to share your expertise with us this evening. Marketing will be editing tonight, and it will be packaged in a YouTube video, so I'm sure you will receive that details as well to revisit any of the information. And Prof Mark for opening and also your presence here. Thank you very much. I wish you all a safe year ahead.